In the SARS CoV-2 positive population, we have seen an increased risk of coagulopathy in patients. The exact mechanism is unknown, and consequentially so is the optimal anticoagulation management strategy. A meta-analysis in August showed the incidence of thrombotic events in COVID patients ranging from 15 to 85%, despite patients being on prophylactic anticoagulation. Perhaps it's because SARS-CoV-2 is a viral infection which causes inflammation and platelet activation, leading to a hypercoagulable state. Since March of this year, multiple studies have been published to attempt to find the best strategy. These findings have ranged from prophylactic doses of low molecular weight heparin, therapeutic dose heparin, direct oral anticoagulants, and warfarin. The International Society of Thrombosis and Hemostasis has recommended prophylactic dose low molecular weight heparin. It's associated with a 24% lower risk of mortality. Research has also found that patients with a positive SARS-CoV-2 diagnosis have a higher D-dimer and have suggested using D-dimer levels to guide anticoagulation. Patients at our hospital were started on a myriad of anticoagulation agents, some on prophylactic dose, some on treatment dose, some were continued on the therapy they had been on outpatient. The objective of this research project is to determine if oral or parenteral anticoagulation impacts the percentage of patients that develop a thrombotic event, either a deep vein thrombosis, DVT, or pulmonary embolism, PE, while inpatient. This research is a single-center retrospective chart review that includes patients admitted from March 1, 2020 to November 30, 2020. Patients will be included if they were 18 years or older, hospitalized for more than 72 hours, if they are treated on the floor or in the intensive care unit, and if they have gotten at least one dose of anticoagulation. Patients will be excluded if they have an active bleed, platelets are less than 50, hemoglobin less than 7, they're less than 18 years old, they have any contraindications to anticoagulation therapy, have a history of heparin-induced thrombocytopenia with or without thrombosis syndrome, or are pregnant. Data regarding patients' demographics, comorbidities, coagulopathy, imaging results, and ADT events throughout the hospital will be collected. Patients will then be stratified into oral and parenteral prophylaxis groups and oral and parenteral treatment groups, as seen in Figure 1 in the bottom middle of my poster. The primary outcome is the percentage of patients developing a DVT or a PE. Secondary outcomes include the percentage of patients with major bleed, time to ICU admission, hospital length of stay, ICU length of stay, and in-hospital mortality. Continuous variables will be analyzed using the Wilcoxon rank sum test. Categorical variables will be analyzing using chi-squared test. Statistical significance will be defined with p-value less than 0.05. The findings of this research project will ideally determine if oral or parenteral anticoagulation affects the percentage of thrombotic events in patients with a positive SARS-CoV-2 diagnosis. It will also ideally determine if prophylaxis dosing or treatment dosing is superior. This research will then be shared with physicians on site to guide anticoagulation management in SARS-CoV-2 positive patients.